Thank you, Professor Nilesh. So the topic of the today's meeting is the resurgence of the surface ablation, and this is one of the causes of resurgence of the surface ablation. So we all know that LASIK requires making a good flap of a particular thickness, and for that you need to apply a good suction. And it was when invented in 1990 by Pellicaris. It has gone a lot of improvement, not in technology but the understanding of the procedure itself. And nowadays, till few years back, it was considered to be the best, one of the best refractive procedures for taking care of the refraction of the eye. And though it was safe, effective, efficacious, but it is not always without complications like any other surgery anywhere in the body of the person. So this is one which is known to have certain complications. Though it is very safe, the complications are very rare. One another important thing is that though the complications are there, but reportings are not, or documentation not that proper, because most of us are not recording the video or the surgical procedure like in phaco surgery or any other procedure where our microscope does have the attachment, the camera, but here in the LASIK procedure most of us are not recording. So it's very rare to have very good video for the any complications. So this is just some of the intraoperative complications. Just going back to this slide, I would say that most of the complications which are nightmares what we face in the LASIK is all because of the during the flap creations. So this is small thing which can happen with anyone during the procedure, even if you don't apply suction, but due to just manipulation of the conjunctiva. So what is most important is to have a very good suction, and good suction is required to not only to stabilize the globe, but let the cornea prolapse into the ring, so that proper depth of the flap is made. And if there is suction loss, then it can create a lot of problems. So that is most important part, and all of us are so much scared of the suction loss during the procedure. So what are the causes of suction loss? Most of the time it is there in the patient's eye. If we are not taking preoperative care, like patient has narrow palpebral aperture, very apprehensive patient, deep set eye, flat cornea, there is improper position or eye of the patient, and there is improper application of suction ring, and you have not properly chosen the size of the ring, you have not applied properly the suction, and if the suction pressure is low, and if there is sudden movement of the patient's eye, it can cause loss of the suction. And these all things has to be taken care of preoperatively, and during the procedure we have to just keep telling to the patient, just remain calm, because it is very frightening, not only for the patient but for the surgeons also. And believe me that this is one stage of the LASIK surgery while doing the pass of, after making this suction, when we pass the microkeratoderm, that is one time when our heart starts beating a lot. So that is the time when we ask the patient to remain calm and always maintain the fixation. And one should avoid draping while draping. One has to take care that you should avoid all the ILSs in the surgical field, so that it doesn't come. And if suppose there is suction or it has happened, then what are you going to do? If the flap if the flap has already been made, which is more than the intended zone of the ablated zone, you can go ahead and do the procedure. And if there is hinge in the ablation zone, then you have to abort the procedure. You cannot go ahead, either retreat after 3 months, and if you are planning for surface ablation, you can do little earlier, but at that point of time you have to just abandon the procedure. These are the small problems which can occur, but that is not much of importance. But only thing is, only care you have to take that if the epithelial defect is bigger, you have to apply bandage contact lens. The complications which are related to the flap are decentered flap. If you are not properly applying the suction ring, then it can create decentered flap. And if you are performing a pupil centered ablation, then the patient's visual outcome may be unexpected. So if you find that the flap has been made which is actually decentered, then it's better to abort the procedure, and you can do the re-laser if sufficient time has passed, say around 3 months. And one thing which is important to see is that if the expected gap between the peripheral edge of the ablation and flap margin is less than 1 millimeter, then you can do the procedures. Incomplete flap is also mainly due to the suction loss, and malfunctioning of the microkeratome, which we can encounter. Sometimes you can end up with the flap tear, but if the flap tear is in the just in the periphery, you can just lift the flap from the other side and go ahead with the procedure. And if it involves the ablated zone or the central area, you cannot complete the procedure LASIK. You can just wait for another few weeks for surface ablation, or you can redo in 3 months. Buttonhole happens only when you are again not taking proper preoperative care and intraoperative care. Like if you are planning to do LASIK in a patient who has very stiff cornea, be careful. If there is suction loss, you should avoid that problem of suction loss. And if you are planning for large flap, and it happens most of the time in the second eye, reasons being that the cornea gets dried, and there are more chances of the buttonholing of the flap. It can result in the irregular astigmatism and epithelial growth. So it has to be managed well about the procedure. And again, the principle is to do the retreatment 3 months after the complications. Free cap is again one of the most dreaded nightmares, which happens to all of the LASIK surgeons once or sometimes in their lifetime. And if it occurs, the reasons being again mainly due to malfunctioning of the old or microkeratome. The cornea is very flat, less around 40 diopter of the keratometry reading. If there is decentered suction ring, and the patient, again, if the patient has not cooperated well, then it can lead to the free cap. And you can prevent this very well if you take all the preoperative cares and intraoperative cares very well, because this is the most important step of LASIK surgery, making the flap, and rest of the things is done by the laser. So one has to be very much careful. And what to do once free cap has occurred? If suppose the flap is intact, you can, and the stromal weight is more than 6.5 millimeter, that is the intended optical zone, you can just remove it. This free cap can be kept in the desiccated chamber, and you can go ahead with the ablation. And after that, you apply the flap, let it dry for 5 minutes, and apply the BCL. And in some cases, there are chances of flap loss also. If you have not taken care and it has actually been lost or washed away, then you can just leave it, let the cornea heal. It will create some hyperopic shift, and then later it can be PRK can be done. This is one of the small video. This is not intraoperative, which actually this free cap had happened, and I applied BCL after taking all the care, after ablating, and the next day the flap actually get little bit dislodged. So this I am just showing that this had happened. The free cap I encountered during the procedure, and next day I encountered another problem. So you have to take care that you reapply it, because there is no mark, so repositioning it is very much difficult. So you are going to have some amount of astigmatism of some power after the procedure. Corneal perforation, though I have not encountered, it can happen. Again, it is very rare, but it's very dreaded complication. If it happens, if it is very small, just stop the suction at that point of time. You can apply the BCL, or if it is large, you have to apply the sutures. But I think that this is one of the dreadest complications. And excimer laser ablation related problem or complications can be there, like central island, where you ablate the cornea in a manner that it has left some part unablated. It happens if there is some debris or something on the cornea. Due to paucity of time, I won't go into that detail. There can be decentered ablation. These are minor problems that can be taken care of. But flap creation related problems that are really dangerous and really dreaded. So if there is decentered ablation, you can manage it later on. Like if you can apply RGP lenses, myotics to reduce the optical aberration, and you can do topo-guided LASIK or PRK later on. The early complications, one of the patient was very much happy after procedure. After 1 hour, the patient was able to read almost 6/9, and then in the night he called that I am having severe pain and something like that. So I counseled the patient. When the patient came in the early morning 6:30, I could see that the flap has actually dislocated. So this is one of the complications which can be seen next day or very early within few days, and it's mainly because of the trauma or squeezing of the patient, squeezing the eyelids. And this is the same patient. And the next morning I could see that actually the flap has dislodged. So again, you have to relift and wash it thoroughly, and let you see that there is no epithelial epithelium inside, so there will be risk of epithelial growth actually. Flap striae is again another problem which can be there, can be one of the nightmares, but if it is detected early, you can very well manage it. And then the problem is that if it comes into the central area, it will just degrade the quality of the vision. So here you have to lift the flap and just wash it, and with 2 sponge you can just milk it perpendicular to the line of the stria. Smaller stria don't create much problem, but the bigger stria create problem. In that case, actually you need to remove the epithelium. Sometimes you have to do actually hot ironing also. Some of the surgeons have reported that. Diffuse lamellar keratitis is one of the complications which can be seen after the procedure, which happens in the interface and causes a lot of problems, and mainly it's because of the glove, talc, marking pain and other things. So that has to be managed. This steroids has to be intensified in those cases. I won't go into that detail already. Macrobial keratitis, again it's very frightening problem or complications which can occur, and I have encountered one patient which had infection about 3-4 days later, and with proper care and antibiotics the things started improving, and at the end of 3 months I could see this. The patient vision was actually 612, so I was happy that at least patient eye was saved. One complication which I just want to mention, then I will finish my talk, that is the epithelial ingrowth, which can be seen in very few cases, few percentage of cases, but in retreatment cases the incidence of the epithelial ingrowth is more, and majority occurs within first 4 weeks, but it can occur later also. And pathogenesis is just implantation of the epithelial cells in the interface during the procedure, or suppose the patient had some trauma and the flap has dislodged or has misaligned, then epithelial cell can migrate through that. These are the patients who are going to have more chances of epithelial ingrowth. Won't go into the detailed theoretical part. This is just small video. This was patient who came 12 years after the LASIK procedure. Is a CISF person who had some fight with some person, and his this flap was little bit dislodged, and he came with this much of the epithelial ingrowth, and patient vision was just 660. So I took the patient to the operation theater. Then you can see that how easily I can still remove the still I can just take out the flap gently. So there is the healing is in the LASIK flap, the healing is not complete even years and years together. So the principle is that remove all the epithelium from the bed, from the under surface of the epithelium, and not only that, you have to remove epithelium around the flap in the bare area of the normal cornea, so that again there is no chances of migration of the epithelium. And since the patient had history of about 1 week back, about 3 months back, so I had to take sutures so that it does not slip away again and doesn't allow the epithelium to go inside. So I put 310 suture in 3 meridians, and then applied the BCL, and this, to my satisfaction, this finished most of the epithelium inside, take care of the epithelium inside. So this is the pre-op picture, this is the post-op. You can see the sutures here, and after removing the sutures about 15 days, you can see the cornea is almost clear. So these complications occurs but can be managed. So take home message is that various complications can occur with the LASIK, and they are really very much frightening to patients as well to the surgeon. However, the rarity of its occurrence results in non-familiarity of most of the ophthalmologists, because most of us are not reporting or not recording. So in-depth knowledge of the complication can help reducing the occurrence, and early identification with appropriate treatment in time can save these eyes from going blind. So reporting complication is necessary, as it is the only way to learn and improve the surgical technique to reduce the complication in future. Thank you so much.
Thank you, Dr. Subhash, for dealing with